Good evening, everyone, and welcome to the FRCS Mentors Group webinar. Thank you for joining us today. My name is Abdullah Hanoun. We have a show up of mentors today. The topic is approaches to the valgus knee osteoarthritis, and our presenter today is Jikku Haniball. He is a specialist orthopedics working in Singapore. He passed the exam in November 2018. And he has special interest in arthroplasty. As usual, you know the routine. This talk is recorded, and you will be able to get to see the copy of it from our YouTube channel. You are more than welcome to ask questions, and me and Dave will keep an eye on the questions you ask and then present it to Jikku, who will be happy to answer it at the end of the talk. After that, we will move to the Viva sessions, and we have prepared some nice questions for you today. This Viva session, again, as you know, will not be recorded. So please feel free to join in, chip in, have courage, and practice. If you have any questions related to the setting, you can put it on the Telegram group, which you can find some more discussions about the topic and other topics. Just to remind you, recently we have published the FRCS book. Again, we are not trying to give you headaches about it. It is just like a contribution from all the mentors. Every one of us has tried to put their best in summarizing what comes in the exam, what are the main topics that can be asked and explained in a nice way with references to other resources which are linked really easily for you to use. None of the cost of the book comes to us at all. It is just to cover the cost. We are not gaining from it financially at all. In fact, it was just a headache for us. We hope that you will find it useful, and please give us feedback on the book because it is a continuously updated, and the third version is we are starting already editing for the third edition. So please give us feedback, any mistakes, anything you would like to add, anything you find was not explained well, let us know. So that was a long introduction. Without further ado, I would invite Jikku to present approaches to valgus knee.
Good evening, everyone. Thank you, Abdullah, for the introduction. Degenerative valgus knee is a common topic that comes in the FRCS trauma and orthopedics exam. It can come in the clinicals, most commonly as a short case, or also even as an intermediate case, and also in the Viva section. And early pattern identification is required. 10% of patients undergoing total knee arthroplasty have valgus knees. Although genu valgum is common in inflammatory arthritis, vast majority of degenerative valgus knee arthritis is due to primary osteoarthritis. It is commonly seen in females with unresolved physiological valgus, and also with persistence of childhood valgus secondary to metabolic disorders like rickets and renal osteodystrophy. In inflammatory arthritis, think about rheumatoid arthritis, SLE, psoriatic arthritis, and gout. Traumatic causes includes tibial plateau fracture, tibial shaft fracture, and physeal arrest. Iatrogenic cause is due to overcorrection of high tibial osteotomy. Start your clinical evaluation by making the patient stand and observing the alignment of the lower limb, which will reveal the deformity. Gait is the best way to assess dynamic instability, and look for valgus thrust and recurvatum in the stance phase. Measure the valgus deformity in supine with a goniometer and check whether it is correctable or whether it is fixed. Look for any recurvatum and flexion contracture and assess the range of motion. Check the competency of ligaments, especially the MCL and the ACL. Look for any systemic features of inflammatory arthropathy and document the status of the common peroneal nerve. Other than the standard knee X-ray views, if realignment osteotomy and unicompartmental arthroplasty are options considered, then ask for Rosenberg view and Valgus stress views. With the standing long leg film, the mechanical and the anatomical axis is critical in planning the distal, femoral, and the proximal tibial resections. The metaphyseal valgus in the distal femur and the proximal tibia is best appreciated in the long leg films. And when you are planning the wedge for the osteotomy, it is done on a long leg film. I will come to that a little later. Genu-valgum deformity can be classified according to the clinico-radiological classification by Ranawat in the long leg films, classified from grade 1 to 3 with increasing severity of deformities. Grade 1 consists of 80% of the cases with mild, less than 10 degrees of correctable deformity with intact MCL. Grade 2, 10 to 20 degrees with attenuation of the ACL but functionally intact. And grade 3 with severe, more than 20 degree deformity with a non-functional MCL. In the AP view, look for lateral femoral condylar hypoplasia, and which affects the distal femoral bone cuts. The bone defects in the lateral tibial plateau and the medial opening are important in determining the proximal tibial resections. In the lateral view, look for the lateral posterior condylar hypoplasia and the location and the presence of lateral tibial plateau bone loss. Also look for the patellar height, as Baha is commonly associated with valgus knees. In the skyline view, look for the severity and grading of patellofemoral arthritis and for patellar maltracking, subluxation, and dislocation of the patella. Whereas stress radiographs are mandatory when considering lateral unicompartmental knee arthroplasty to assess the presence of full thickness cartilage loss in the medial compartment and to confirm whether the deformity is fully correctable to neutral, which is one of the prerequisites for lateral UKA. Rosenberg view is the best radiological view to evaluate lateral and medial tibial cartilage wear, critical when considering an osteotomy or a unicompartmental knee arthroplasty. Surgical options other than total knee arthroplasty includes lateral unicompartmental arthroplasty and distal femoral osteotomy. The aims of total knee arthroplasty in valgus knee is similar to other indications of total knee arthroplasty. Depending upon mainly the surgeon preference, total knee arthroplasty in valgus knee can be carried out either by a medial or a lateral parapatellar approach. Medial parapatellar is the standard approach which is familiar for the most orthopedic surgeon. Eversion of the patella in this approach is easier due to a combination of valgus deformity and lateralization of the tibial tubercle. Disadvantages of this approach includes limited access to the lateral structures, especially the posterolateral corner for soft tissue release. This approach could lead to patellar devascularization if additional lateral release is required to improve patellar tracking. Lateral parapatellar approach allows for better direct surgical view for the lateral contracted elements, which facilitates its release. There is no risk of patellar devascularization as the lateral release is a part of the approach and the medial vascular supply for the extensor mechanism is untouched. If tibial tubercle osteotomy is done as a part of the approach, it is possible to medialize and improve the patellar tracking. With the lateral parapatellar approach, there is difficulty in patellar eversion, and there is limited medial compartment exposure if tibial tubercle osteotomy is not done. After adequate releases laterally to achieve balance, there may be a defect in the lateral retinaculum during the retinacular closure, which requires advancement of the fat pad or a Z-plasty of the capsule to facilitate the closure. Let us now talk about the bone cuts. In the valgus knee, the valgus angle cut referenced off the anatomical axis is reduced from the normal 5 to 7 degrees of valgus to 3 degrees so as to compensate for the metaphysio-diaphyseal valgus remodeling and to avoid undercorrection. Caution is taken not to over-resect the lateral femoral condyle to avoid marked elevation of the joint line. The proposed femoral resection is kept minimal, usually around 8 mm from the medial condyle and no more than 10 mm. This may result only in minimal or no lateral condylar resection in severe valgus deformity cases. Tibial resection is kept to the minimum, usually only around 5 to 8 mm or from the medial tibial plateau with minimal or no bone removed from the lateral side in severe valgus knees. With regard to femoral component rotation and sizing, lateral condyle hyperplasia makes posterior condylar referencing inaccurate. There is a tendency to put the femoral component into internal rotation with excessive resection of the already hypoplastic lateral posterior condyle. This internal rotation of the component increases the Q angle by obligate medial placement of the trochanteric groove and results in abnormal patellar tracking. This also results in trapezoidal flexion gap wider laterally. Rotational referencing should be done on the anteroposterior Y sides line or with the interepicondylar line in valgus knee. If posterior condylar referencing is used, dial in more external rotation, about 5 to 7 degrees from the normal 3 degrees to build up on the posterior aspect of the lateral condyle with an osteotome during sizing and determining the rotation. In severe valgus knee, the structures, there are tight lateral structures. There will be laxity of the MCL and the PCL. The tight lateral structures can be of two types. There are structures which are inserted at the flexion extension axis at the lateral epicondyle. That is the lateral collateral ligament and the popliteus tendon, which is isometrically tensioned in both extension and flexion of the knee. And the structures inserting away from the axis, like the IT band and the posterolateral capsule and the lateral head of the gastrocnemius muscles, which act only in extension. After executing the bone cuts, there are two possibilities. One is a symmetrical rectangular flexion extension gap when no further release is necessary. And the other possibility is that the gaps are trapezoidal when further soft tissue releases are necessary. The best sequence and the technique to perform the lateral release in valgus knee is debatable. One popular technique is the Ranawat's inside-out technique. In this technique, the knee is extended and spread out with a lamina spreader. Palpate for the tight structures laterally, which hinders the balancing of the gaps. In this technique, the first structure to be released is the posterior cruciate ligament. Then after that, the posterolateral corner is released from the cut surface of the tibia from the PCL to the posterior border of the iliotibial band. And then we release the IT band by multiple stab incision 1 centimeter proximal and higher to the tibial cut surface. If the knee continues to be tight in flexion, rarely popliteus tendon can also be released. After the lateral structure release, if the gaps are not balanced, one may consider MCL advancement. That is, the epicondylar origin of the lax MCL is advanced proximally and secured with a suture anchor or a staple. The other option for MCL tightening is MCL imbrication, where the mid substance of the ACL is divided and imbricated to equalize the joint gaps. Check the tracking of the patella after releasing the tunicate. If the patella lateral maltracking persists after confirming the optimal component position, a lateral release is to be performed. In the inside-out technique, the lateral retinaculum is exposed and the retinaculum is incised from the mid-patellar level to the upper tibial border 1 centimeter lateral to the patella. Further proximal retinacular release endangers the superior lateral genicular artery, and usually it's not required to extend it superiorly. In mild deformities, where soft tissue balance can be restored without PCL release, a minimally constrained CR component could be implanted. In valgus knees, most surgeons prefer a PS implant as the PCL is non-functional. The PS implant also allows greater lateralization of the component with better patellar tracking. Although the PS component provides some degree of posterior stabilization due to cam-post mechanism and also some translation in the posteromedial and the posterolateral direction, it will not protect against residual medial laxity. In severe deformities, where there is significant collateral laxity, a varus valgus constrained implant may be necessary. Component augmentation may be required if there is bone loss and to restore the joint line. The Krakow, in his review article, noticed increased incidence of instability, recurrent valgus deformity, and patellar complications with valgus knee, total knee arthroplasty. The common peroneal nerve palsy incidence was found to be 3 to 4%, which was attributed to the traction of the nerve during the lateral lengthening or the direct injury while performing the pike cresting technique. If the common peroneal nerve palsy is discovered post-op, the compression dressings are removed and the knee is flexed to relax the tension of the nerve, and an expectant management is advised. Distal femoral osteotomy is the osteotomy of choice in valgus knee. An ideal candidate for distal femoral osteotomy is a younger, active patient who is able to comply with postoperative rehabilitation, which includes non-weight bearing walking for a period of time, in the presence of valgus malalignment associated with isolated early lateral compartment arthritis. Distal femoral osteotomy is contraindicated in tricompartmental osteoarthritis, inflammatory arthritis, or severe articular disruption of the lateral compartment. Valgus deformity more than 20 degrees, flexion contractures more than 15 degrees, and knee flexion less than 90 degrees are also contraindications for distal femoral osteotomy. Relative contraindications include ligamentous instability, which needs 1 or 2-stage reconstruction along with the osteotomy in case of associated ACL injury. MCL laxity seemed to improve after distal femoral osteotomy. Even though distal femoral osteotomy is favorable with regards to alignment in patients with high BMI because of improved thigh clearance, because of increased complications, BMI more than 30 is a relative contraindication. As patellofemoral articulation improves after distal femoral osteotomy, mild to moderate patellofemoral arthritis is not a contraindication for the osteotomy. Severe osteoporosis and nicotine use is related to delayed wound healing at the osteotomy site. The two main types of distal femoral osteotomy are the lateral opening wedge osteotomy and the medial closing wedge osteotomy. The type of the osteotomy is mainly based on the surgeon preference, but the general consensus is that moderate corrections up to 12 degree of correction is better obtained by a lateral closing wedge, and for larger correction more than 12 degree, a medial closing wedge distal femoral osteotomy could be a better choice. Advantages of lateral opening wedge osteotomy include better control of distraction when optimizing the mechanical axis. It's a more familiar approach to the lateral distal femur for most surgeons. Advantages of the medial closing wedge osteotomy is direct bone-to-bone healing and avoidance of bone grafting in the open wedge technique. Correction achieved is better maintained. Although nicotine use and osteoporosis are relative contraindications in osteotomy, medial closing wedge osteotomy is preferred over lateral opening wedge in these situations because of better healing. There is less hardware rotation because of the plate not being directly under the iliotibial band. Rosenberg view is a mandatory view in distal femoral osteotomy. Most surgeons believe that either an MRI or an intraoperative arthroscopy should be performed in diagnosing chondral, meniscal, and ligamental alterations before the osteotomy is performed. The osteotomy planning is done on long leg films by the Dugdale method. The correction angle is calculated by the angle formed between two lines. The first line drawn from the center of the head to the 50% coordinate in the medial tibial plateau, and the second line drawn from the center of the angle to the same point. By measuring the width of the femur at the level of the proposed osteotomy, surgeon can convert the angular correction into the wedge size required. Backstein, in his series, demonstrated 10-year survivalship of 82% with a significant decline to 45% at 50 years after distal femoral osteotomy. Lateral unicompartmental arthroplasty is 10 times less performed than medial unicompartmental arthroplasty, thus representing less than 1% of all total knee arthroplasty, 1% of all knee arthroplasty. Because of the low numbers, limited long-term results are available for lateral UKA. An ideal candidate for a lateral UKA is a patient with isolated bone-to-bone arthritis in the lateral compartment with preserved medial pivot with intact anterior cruciate ligament with fully passively correctable valgus deformity. Other than tricompartmental and inflammatory arthritis, valgus more than 15 degrees, any non-correctable valgus, range of movement less than 100 degrees, and any flexion contractures are absolute contraindications for lateral unicompartmental arthroplasty. Recent studies have shown that lateral UKA wear is more related to activity than to BMI. Ligamentous instability needs to be corrected before the lateral UKA, and previous osteotomy or any surgery altering the knee biomechanics, a total knee arthroplasty should be considered over lateral unicompartmental arthroplasty. Lateral UKA is technically more challenging than medial UKA due to anatomic and biomechanical differences between the two compartments. The main differences are the relative lateral ligamentous laxity, lateral femoral condyle being more divergent and convex, medial pivot and the lateral condylar rollback, and the screw home mechanism in extension. Due to these factors, there is more chance of component dislocation and femoral component impingement on the patella in flexion and the tibial spine in extension. To overcome the dislocation risk, some authors suggested fixed bearing implants for lateral UKA. Impingement can be minimized by lateralizing and avoiding oversizing of the femoral component. In a recent systemic review on the survivalship, even though the lateral UKA is more challenging technically, both the lateral UKA and the medial UKA was found to have similar survivalship with no statistical difference in the survivalship. The lateral UKA survival at 5, 10 and 15 years respectively was 95%, 93% and 89% respectively. Thank you.
For the other questions, I have a couple of questions for you. Does age play any part in choosing which one do you go for? Do you go for, do you have like a cutoff where you say, definitely I'll go for total knee replacement rather than a uni or a osteotomy, or age doesn't play any part in it?
Yes. So more than age in lateral unicompartmental knee arthroplasty, it is the activity level of the patient that decides the choice of the surgery. In case of distal femoral osteotomy, the patient should be relatively youngish patient who is able to cooperate with rehabilitation, use of walking aids and non-weight bearing walking. In case of unicompartmental, there is no age limitations. You can do unicompartmental knee replacement in any age group, but the survivalship is less if the patient is more active. So activity level determines which is the surgery of choice for a particular patient.
Mm-hmm. Okay, the other question is, now, do you have an algorithm or a guide on which one to choose? For example, you've got a 50-year-old office worker who's coming with a valgus knee. Would you go for a total? Would you go for a uni? Or would you go for osteotomy? This is the exam scenario. They present you with that and they ask you which one do you go for. How do you choose and how do you phrase your answer in the exam?
Right. So a 50-year-old patient, like we will be more inclined to doing a distal femoral osteotomy. So my answer will be that I will be taking a detailed history, especially looking at the activity level of the patient and the functional limitations of the condition, what the condition, what functional restriction the patient is having. I would ask about the, like, whether the patient is a smoker, what is the medical comorbidities of the patient, whether the patient will be able to like cooperate with rehabilitatory, whether the patient has got rehabilitatory potential to avoid to cooperate with non-weight bearing walking post-operative. Then I will be basing my decision based on these factors.
Absolutely. Fine. Another question from Birivan. He asked about how do you differentiate between Rosenberg and tunnel views?
The Rosenberg view is another name of the tunnel view. It is actually, it's a postero-anterior view of the knee taken in 45 degrees of flexion with 10 degrees of caudal angulation of the X-ray beam. So according to my knowledge, the tunnel view is same as the Rosenberg view. If anybody else...
I looked into that one as well, but yeah, so a tunnel view is looking at the intercondylar notch more so than Rosenberg view. And one big specific difference is Rosenberg is generally weight bearing and a PA view. A true tunnel view is non-weight bearing and AP view.
Okay. Yeah.
So that's my understanding. But I mean, what we might consider a tunnel view and what a radiologist might consider a tunnel view is completely different. That's the problem sometimes.
In reality, I think both are interchangeable and people use one for the other. So as long as you know basically what you are looking for, I think it's in real life, in the exam, they will forgive you, I think, if you mention it, unless you've got you are unlucky and you've got a particular examiner who would want you to know the difference between the two. I don't think that matters, no.
I would say though, you be prepared if you're going to say Rosenberg view in a Viva, just have a quick, I'd say, just if they do say, what's a Rosenberg view? Just say quickly, oh, it's a PA view, weight bearing, 30 degrees or 45 degrees bend. That'll be fine.
Perfect. No one will ask you what's the difference between that and the tunnel view unless you mention both. So, that's the thing. The technique of the exam is the examiners are not there to trick you. They will ask you, and they will ask you based on what you say. So if you say Rosenberg, they may ask you what Rosenberg is. They will never ask you how do you differentiate between that and the tunnel view.
Yeah.
Okay, fine.
Just want to add something for the age regarding whether to use a unicompartmental or total knee replacement. There is a nice paper published last year in the BMJ. Actually, the age is not a factor. So whatever the indication for the patient and X-ray, if it's suitable for unicompartmental, will do that. However, you may discuss that with the patient according to the pros and cons of everyone.
Yes.
Like the rate of revision is a much more in the unicompartmental than the total knee replacement. But the age itself, it is not a factor. And sometimes it irritates the examiner to say, I will do the unicompartmental in young patients and do total knee replacement in old patients. Sometimes it's not the better answer to say.
Yeah.
Okay.
So you can mention it's a physiological age rather than chronological age for this.
Yeah.
Okay. Next question. Muhammad Al-Gawadi, I may have to ask you to explain it. The question is written, how do you differentiate between valgus knee due to osteoarthritis and that due to rheumatoid? If due to osteoarthritis, you will deal with it in a different way. So I'm guessing because you mentioned that osteoarthritis is a contraindication, how do you differentiate between the two? Is that what you wanted, Mohammed?
I mean, if you have advanced degree of osteoarthritis and you are going to replace the knee, how you differentiate from the radiology that this is due to advanced osteoarthritis or is it inflammatory arthritis? With its surgical tips and tricks that the hypoplastic lateral and posterior femoral condyle.
Okay, so in case of radiologically differentiating between an inflammatory arthritis and osteoarthritis, in inflammatory arthritis, there will be a distinct symmetrical collapse of the joint space. And osteoarthritis, likely it will be an asymmetrical collapse of the joint space with opening up of one compartment with the obliteration of the space on the other side. The other features of inflammatory arthritis will be evidence of soft tissue swelling, the associated periarticular osteopenia and paucity of osteophytes. That is how those are the radiological differences between inflammatory arthritis and osteoarthritis.
In addition, the patient normally can tell you, because as you know, inflammatory arthritis is multi-joint. So they will usually come with more than one joint at the same time, including, it's a systemic disease. So bilateral, symmetrical arthropathy, usually. In addition, if you have 3 compartments, then by definition you can't, whether the reason is osteoarthritis or rheumatoid, because you can't apply Valgus technique if it's tricompartmental. And that's the reason for the rheumatoid arthritis being excluded, because it affects all compartments at the same time. So, for example, if you do osteotomy, it'll fail very quickly because the disease is progressive. The same thing about unicompartmental knee. Does that answer your question, Mohammed?
Yes, to some extent. Yeah, because I exposed to a valgus knee, we were replacing the knee, but we don't know. You cannot detect from the preoperative X-ray if the lateral and posterior femoral condyle is really hypoplastic as inflammatory arthritis, and in this case you have to depend on the interepicondylar or the right side line, or you will deal with it as a conventional osteoarthritis with no tips and tricks.
The thing, go on, Jikku.
It was confusing.
Irrespective of the etiology, whether it is because of osteoarthritis or inflammatory arthritis, lateral femoral condylar hypoplasia is likely to be present in valgus knee. So in case of valgus knee, like while you are determining the femoral rotation and sizing, if you observe a disparity between the epicondylar line and the white sides line with regards to the posterior referencing, then you have to be careful. You usually depends on either the AP axis line or the intercondylar in the epicondylar line for your rotational referencing.
Yeah, it's always a good technique to not rely on only one method. I know many surgeons who would rely on the posterior referencing and white side lines, and they measure both, and if there is a discrepancy, they will dial it like an external rotation in the matter. It's just a matter of making sure that you are doing it correctly. Fine, moving on. So the next question is from Nabad, and he says, in general for valgus knee, which approach is considered the standard one, medial or lateral?
Yeah, so basically, like, you know, I have seen in my practice like hardly 1 or 2 like lateral approaches to the valgus knee, even in mild. So basically, when you consider mild, moderate, and severe, mild cases accounts for around 80% of the cases. So there is no ambiguity that we should be going. Usually, we'll be going with a like a medial parapatellar approach. But the question comes when in very severe knees. In very severe knees, even with the medial parapatellar approach, what I find is your exposure is adequate, because as I mentioned, your patellar eversion is easier, and you have got reasonably good generalized better exposure of the knee, and you have an access to the lateral structures even with the medial parapatellar approach. But there are surgeons who does lateral parapatellar for very severe valgus needs. But for me, I always go medial.
With regard to answering in the exam, the key thing is to say, in my practice, I will use the medial parapatellar approach, because that's what I know and that's what I'm comfortable with. However, I understand the principles behind the lateral valgus approach and say it that way. Get out of jail. They want you want to demonstrate that you're a safe, competent surgeon, not someone who's going to try. Because if you suddenly just say, I'm going to do the lateral approach, they might go, how many times have you done a lateral approach? And I think I've worked with many knee surgeons, and Jikku, that they would say they've probably only done it sort of 10 times in their whole career out of 1,000 times they've done the medial approach. So it is a very rare approach, but as long as you can say, I understand the principles behind, that will get you through.
Another scenario that may come in the exam is if it is severe valgus and the decision tree led you to doing a knee replacement, then it is safe to say, in this case, it is significantly severe valgus knee, and I anticipate that the ligaments would have contracted and all of that. I'd rather a arthroplasty surgeon who does this frequently deals with that, because this may need a lateral parapatellar approach, which I know the principles of, but I haven't done enough. So again, this is another get out of jail card, which you can use, but that is only if it is severe, because as Jikku has mentioned, it is 80% of the cases is mild, where medial parapatellar approach is enough. Another question, he was asking, and that's Isam, I think he was asking, should we prefer to use PS knees in inflammatory arthritis? I think I got that right. Please, Isam, if that is the wrong question, if I didn't get it right, please correct us. Isam?
Yes, I'm asking about osteostabilizing or sacrificing. I think it's sacrificing because PCL will not be competent in rheumatoid arthritis. That's right.
Jikku.
Yeah. So in inflammatory arthritis, like it is one of the previously described indications for a PS knee, but there have been papers which suggested CR implants or anterior stabilized or condylar stabilized implants for inflammatory arthritis. So recently there is more of a trend in using a cruciate retaining implants even in rheumatoid arthritis. But for the exam, I think we can still stick with the answer that inflammatory arthritis, you will go for PSVs.
Excellent.
Thank you.
Thank you.
Thank you.
May I ask everyone else who's not asking the question to mute, please? And I will ask the next question, but while we're waiting, anyone who is interested in doing the Viva, please raise your hands. I've got 3 people who have raised their hands so far. We've got many nice Viva questions today for you guys, so please contribute. If anyone is interested, raise your hand by clicking on the raise hand button underneath the underneath your name. So the next question is from Muhammad Gawadi again. Do we have a limit in the valgus angle when we do distal cut?
Limit, yeah, usually, like, you know, when in your general practice, you usually cut a 5 degrees, between a 5 and a 7. That is your normal standard, whereas OA knee cut will be. In case of taller people and in case of valgus deformity, your distal femoral condylar cut should be reduced to up to around 3 degrees. So this in valgus knees is because there will be a valgus remodeling of the distal metaphyseal diaphyseal region. And when you put in your intramedullary guide, there is a bit of inbuilt valgus in that measurement itself. So you reduce your valgus cut to around 3 degrees. But the more critical question that you are asking is how to get a neutral mechanical alignment, which is we got by cutting perpendicular to the mechanical axis. So as long as you do your templating of the distal valgus cut, drawing your mechanical axis on the long leg films, you will get an idea about how much valgus cut you require. But hardly ever you go less than 3 degrees valgus cut in TKRs.
Okay. Another question, which is about the rehab post the osteotomy. What is your protocol for rehabilitation after a femoral osteotomy?
Yeah, so my protocol for distal femoral osteotomy after distal femoral osteotomy depends on the type of osteotomy that I do. I usually do a lateral opening wedge osteotomy. With the lateral opening wedge osteotomy, you definitely require non-weight bearing to toe touch weight bearing for at least 4 weeks. With a medial closing wedge osteotomy with more stability of the osteotomy with bone-to-bone contact. I don't do medial closing wedge osteotomy, but even if you do medial closing wedge osteotomy, we can allow bit more weight bearing. Around 50% weight bearing can be allowed. So usually around 4 weeks of non-weight bearing to toe touch weight bearing in case of lateral opening wedge osteotomy. That will be the range of movement to begin immediate post-op.
Excellent. Good. Thank you very much, Jikku. I know that you have other things to attend to. It's the time difference. I think it's time for you to go be somewhere. Any other questions, guys? Okay. Thank you very much, Jikku. It was very good, very comprehensive and clear answers. Thank you very much for all the people who posted questions. I will now end the recording, and then we will move to the Viva session.